Good day, everyone, and welcome. Welcome to the May 19th, 2021 edition of the Med Safety Exchange. And thank you for joining us. My name is Mike Hamilton. I'm a medical director at Icmp Canada. And this webinar is a production of Icmp Canada and CMERPS with contributions from all our partners in medication safety and certainly you, the audience. We host this webinar to encourage reporting, sharing, and learning of medication incidents and medication safety topics. We learn best from each other, and we truly appreciate the generosity of our presenters in sharing their expertise and their experience. And we hope that you can use this information presented in the webinar in your own organizations, and in turn, to share your experience with others. The Med Safety Exchange is presented on the Zoom webinar platform. And a few reminders that'll help optimize your viewing and participation is you must register before the webinar. You can sign in at any time. You must use the computer audio. We do not have the ability to offer phone lines. And for best results, ensure your computer audio is sufficiently loud. You as audience members are automatically muted and your video is disabled. So we can't see you, but I'm sure you look terrific. It's helpful to maximize the Zoom window to better see the slides. And the presentation part of this webinar is being recorded and will be available on our website along with links to various materials in about 2 weeks or so. And one thing you'll note again is that the presenters don't have control of their slides. I do. So you'll hear next slide, please, to trigger me to advance. Feel free to submit questions. Find the Zoom toolbar, which is typically at the bottom of your screen in most occasions. You'll find a number of options. We've disabled the chat or we'll ignore it. Raise hand is also disabled or we'll ignore it. If you select the Q&A tool, that's your direction to submit questions. A window will open up. And feel free to submit any comments or questions via that tool. You'll have the option to submit anonymously if you wish by checking off the lower box, and your question or comment will go to the presenters and they'll answer what they can through that. Your question will not be visible to other people until it's answered. And those questions that we don't get to, please email us at medsafetyexchange@icmpcanada.ca and we'll try to answer the best we can offline.
Now for today's overview. This webinar will have two excellent presentations. Now, although medical cannabis has been available in Canada for some time, it is still an area where clinicians lack awareness and our safety systems lack visibility. And at Icmp Canada, we really don't receive many medication incidents related to cannabis. So in our first presentation, we'll hear about an incident involving cannabis, learn about some of the regulatory structure surrounding cannabis, and suggest some ways to improve awareness and reduce harms. And anyone who's involved in providing COVID-19 vaccinations knows of the depth and breadth of the task. And so there are many considerations and so many moving parts. So in our second presentation, we're going to hear about how a large organization used the proactive assessment method called the failure mode and effects analysis to inform the processes that they put in place for their vaccination initiatives. Now, their story is an excellent real-life example of how to use the Fmea to develop and improve processes. And finally, we'll finish by visiting the Observatory, where we'll hear about very quick updates from Icmp Canada's analysis team. Next slide. So we'd like to thank Health Canada for presenting a cannabis-related incident that their team reviewed. The presenter will give some background related to how medical cannabis is accessed in Canada, along with a comparison between medical cannabis and more conventional prescription medications. So Mike Hamilton will then continue the exploration of the prescribing and accessing situation, and then follow with some recommendations to improve safety.
So my name is Nadia Aziz. I am one of the regulatory affairs specialists, work for Health Canada at the Office of Cannabis Science and Surveillance, as well as I am community pharmacist. I would like to thank Icmp for giving me the opportunity to present this case report that we received regarding a pediatric patient was using cannabis for medical purpose, and the opportunity to improve awareness and reduce harm. Next slide. See, so the objective of this presentation is to summarize the case report that involved the pediatric patient with cannabis for medical purpose, to provide overview about the medical purpose program, the medical authorization, and to highlight the area that we can improve to reduce the medication error and to reduce the harm for cannabis for medical use. Next slide, please. So the case report we received, the child had been initiated on a CBD dominant product, which is 20 milligram per ml of the CBD and less than 1 milligram per ml of THC for a rare neurological condition following consultation with a neurologist who issued the medical document for cannabis for medical purpose. The caregiver had been ordering the CBD dominant oil from the licensed holder on 5 occasions, twice in July, twice in August, and once in September of last year, until the last occurrence where they ordered the high THC product rather than the high CBD product. So the high THC product was 20 milligram per ml of the THC and less than 1 milligram per ml of CBD. Unfortunately, the caregiver had administered the high THC product oil to the child, which led to a serious accidental overdose, THC intoxication, and reappearance of the seizure due to the medication error, leading to the hospitalization. Next slide, please. So, as many of us know, there are two main cannabinoid in the cannabis sativa plant, the THC, which is the chemical name, delta-9 tetrahydrocannabinol, which is the psychoactive and responsible for a high-end intoxication. And it has some therapeutic effect, but also it has some harm effect. While the second one is the cannabidiol, which is also known as a CBD. It doesn't produce any high or intoxication. It's used for many therapeutic effects, mainly used for its therapeutic effect. So here we are going in this slide to talk about the medical access. So Canadians have a constitutional protected right to reasonable access to cannabis for medical purpose, and the Cannabis Act are associated with regulation to provide legal access to cannabis for medical and non-medical purpose. Next slide. So continue on the medical access. Patient authorized by healthcare professional can access cannabis for medical purpose. It's either from the federal license seller, or they can register with Health Canada to produce their own or designate someone to produce it for them. And also it can be accessed from the province and territorial authorized seller for adult use only. So in this slide, it's we are doing a comparison between how prescription medication, between the conventional prescription medication and cannabis for medical use. So they are different in regulation. They are different in who can prescribe or write the medical document. They are different in labeling and packaging, as well as who provides the final product. Next slide. So this slide is explain the regular prescription that healthcare professional write and the patient submitted to the pharmacy. It's either hospital or community pharmacy. It has all this information about the prescriber, patient, instruction how to use, of course, the prescriber signature, date, medication name, dose, if there's any refill, how to take the medication, frequency and quantity to dispense. Next slide, please. In this slide, it shows the medical document for cannabis. It's the minimum requirement by the federally to have authorized healthcare professional information, signature and the number, patient information, and daily authorized amount for cannabis and duration for authorization. Of course, the date of the medical document. Please note this medical document expires after 1 year, so it's not valid after the year. Next. I think now Michael is going to continue with the next slide. Thank you.
Thank you, Nadia. Terrific beginning here, and we'll continue an exploration of the differences between conventional medicines and cannabis by looking at packaging and labeling requirements. A few years ago, Health Canada and Icmp Canada published a good label and package practices guide for prescription drugs. And it outlines the expectations of a drug label. And these are really reflective of similar things that we'd expect that Nadia showed you in a couple slides ago that are included in a conventional prescription and include, drug names, strengths, routes of administrations, all the things we would need on a prescription to safely understand and act on that information alongside other critical information like warnings and handling instructions. These are designed with the intent to add safety, improve discrimination between products, and provide the needed information for safe and effective use. Labeling and packaging guidance for cannabis takes a slightly different path, although the goal remains the same to provide consumers with accurate information about the content and the use of the cannabis product. The approach is similar to that taken by cigarettes, and we'll see an example in a few slides down the road. Recommendations for relatively plain labeling and packaging to both reduce the attractiveness and appeal of cannabis products, particularly to young persons, but also to make the standardized cannabis symbol and other warning messages more prominent and noticeable. The standardized cannabis symbol only applies, though, to cannabis products that contain more than 10 parts per million of THC. And there are also various other packaging and labeling requirements, including the standardized warning messages, the content of cannabidiols, and some brand naming and brand elements. And there are additional restrictions to things such as added ingredients, depending on what product class this is. Most of us, I think, will be at least familiar somewhat with the pharmacy dispensing process from intake, input into the pharmacy system, filling the prescription or preparing the prescription, ensuring the prescription is the correct one intended, and final counseling of the patient on product use and potential effects. And throughout this process here, there are built-in technical checks, so ensuring the product is the correct one in the correct form and strength. And there are clinical checks, so using the clinical knowledge acquired by a regulated healthcare professional in the context of the patient or recipient's other medication and health status to ensure the medications will be safe, effective, and well tolerated. If we explore a similar path for cannabis, we'll notice a few differences. Firstly, the cannabis is provided by the federally licensed seller, the license holder in this case. The healthcare provider or practitioner electronically transfers or faxes the medical document you saw a few slides ago to the license holder, which authorizes access to medical cannabis for the patient up to the specified daily amount for the specified duration. The cannabis product itself is selected by the patient or directly from the license holder through an online medical access portal. And this is informed by decision-making between the authorizing healthcare practitioner and the patient and caregiver. Selection of which cannabis product is really up to the individual, giving the various reasons for use, such as response to previous cannabis products and patient preference. So for pediatric patients, the interaction between the caregiver and the healthcare practitioner is really, really important for decision-making. selection, type and dosage, and follow-up is also critical. The product the patient selects is then prepared by the license holder, and then verification occurs, making sure it's the intended product and it falls within the specified daily amount of dried cannabis and any other restrictions placed on the medical authorization form. And then the cannabis is couriered to the patient. I think in this process, it's critical to point out that the license holder, what we might term as dispenser, but more appropriately license holder, does not act in a clinical capacity. They are not regulated healthcare professionals. They only provide the product, but cannot counsel patients in a clinical way. So that makes the patient assessment, the initial patient assessment, the initial treatment determination and counseling by the authorizing healthcare provider so much more important. Healthcare providers who authorize cannabis, they are usually mandated by the jurisdictional college for their professional practice, for authorizing medical cannabis, and also for requirements regarding follow-up, especially for new patients. What we've learned in the previous slides and apply it to our original case of the child experiencing an overdose of THC by selection of the wrong product, we can identify a few key contributing factors to the incident. One, there was no THC restriction on the medical authorization document, which may have otherwise alerted the license holder during a technical check that this was not the correct product. And secondly, as we'll see in the next slide, the plain packaging and labeling requirements introduce look-alike vulnerabilities when selecting products. Investigation of the incident revealed the patient was really unaware of the differences between the effects of THC and CBD. And when you couple this with the patient onus to select their own products, you can see how these errors might occur. License holders, again, do not counsel patients on products they select because they're not healthcare providers, but they can perform technical checks against the medical authorization document and against previous purchases. Had this been performed, especially against previous purchases, the discrepancy may have been noted and acted upon. And here's an example of the lookalike packaging label that does exist. You'll note that the circled area specifies THC and CBD content and how it might be easily overlooked or misread. The brand name and strain are also often difficult to discriminate between brands. And one helpful warning item is the THC warning in the top left. If cannabis contains, or the product contains more than 10 parts per million THC, it must carry this symbol on it. However, again, it only acts as a warning if the patient is aware of the significance of the THC. And for the remaining few slides, we'll highlight some recommendations that may prevent similar errors. And as mentioned, the discussion between the authorizing healthcare provider and the patient is critical. And although the medical authorization document is not product specific and not intended to be product specific, the details and recommendations can be imparted to patients in some other way via conversation or a patient takeaway or a patient handout. Ultimately, though, patients may choose to select more than one type of product because the authorization based on a maximum daily amount. And the patient has a wide latitude in selecting what products they wish. The authorizer can also aid by adding restrictions on the medical authorization document, which may have been helpful in this case. And for pediatrics, specifying no THC might have also been helpful. And it's important as well for healthcare providers to remain informed and to ensure the patients remain informed. And there are a number of excellent resources from Health Canada that we'll provide links to at our website. Recommendations for license holders include to perform robust technical checks against medical documents and authorizing documents and any other restrictions, and the patient's purchase history to note if any changes are accidental or intentional. And although there are restrictions in packaging and labeling allowances, more and clear information, warnings, strengths, concentrations could be presented in the online selection portals that might be helpful. And in certain cases, license holders have co-located with healthcare practitioners in more of a team approach to help authorizing and access and answer any questions. Recommendations at a regulatory level include formalizing some of the recommendations noted above, including the requirements for more detail on the authorization document and strengthening guidance for healthcare practitioners and patients alike. And also includes reinforcing the need to provide technical checks and improving the quality of such checks. And important for all of us as patients, caregivers, and practitioners is to be aware of the risk of adverse reactions and errors and to report them if we come across them. Reporting was how this medication incident and the opportunity to learn from it was made possible. So please help improve safety by contributing. And in this episode, or in this segment, we learned about how a patient and caregiver switched to the wrong product between a cannabis dominant product and a THC dominant or cannabidiol dominant product and a THC dominant product due to confusing packaging and labeling. And we also learned about the lack of validation against previous orders was a missed opportunity to catch the discrepancy. And we learned of the many differences between conventional medications and access to cannabis. So the Healthcare or Health Canada team is really eager to hear from you and your comments and questions. And if we cannot get to them today in the Q&A box, please share with them via the email cannabis@canada.ca. So a few key learning points from this is unlike a conventional prescription, authorization for medical access to cannabis doesn't specify a particular formulation or product, but rather allows access up to a specified limit of dried cannabis. And there are numerous opportunities as presented above to improve safety through enhanced communication, patient counseling, and technical checks. And as your medication safety exercise, how well does your organization collect pertinent information on medical cannabis during a BPMH or patient counseling? What sort of information do you collect? All of these parameters might be useful in ensuring the safe use. And now in our next segment, we'll co-present Icmp Canada's experience working with the Saskatchewan Health Authority to identify and address potential problems associated with the provincial rollout of the COVID-19 vaccine. And we'll start with a very high-level overview of Fmea, and then we'll have the terrific team from Saskatchewan give us more details about the process. Ambika?
Great, thanks, Mike. As Mike mentioned, I'll provide a brief overview of the Fmea process and short examples from the working session that we had with the Saskatchewan Health Authority team. And then I'll turn it over to representatives from Saskatchewan to expand on that work done to complete the analysis, to develop the strategies, and to actually implement and monitor them in practice. Next slide, please. So first, what is an Fmea? So it's a prospective, team-based, systematic approach, and it's a technique used to identify process and product problems before they occur. So it accomplishes this by evaluating systems and processes to identify ways that the process or design can fail and why. And as well, it allows you to identify and correct vulnerabilities that you discover. So in other words, how the system can then be made safer to prevent or minimize the risk of errors. And this ultimately leads to improving overall quality and safety. So the Fmea focuses on how and when a system will fail, not if a system will fail. Next slide. So an Fmea is conducted in a systematic stepwise manner, and typically this includes 8 steps as shown on this slide. So of course, we won't be able to go through all 8 steps together, and instead I'll do a targeted look at some of the high-risk components of the vaccine rollout process that was covered during our working session. Next slide. So this is the overarching client journey from the point of being informed that they're eligible to receive the vaccine through to exiting the vaccination site. And these processes are broad enough that you could actually conduct an FMEA on any one of them. And each team from the Saskatchewan Health Authority was responsible for further defining and analyzing one process or sub-process during that working session. So for today, step one, selecting the process, will be the process of vaccine administration and documentation. Step two is to define and diagram the process and sub-processes. So at a high level, vaccine administration and documentation entailed procuring the vaccine supply, setting up the vaccination area, preparing the vaccine, preparing and administering the dose, and documenting this in the system and in the patient's record. So we focused on the details of dose preparation and administration, and then the sub-process steps of receiving and the reconstituted vial, drawing up the dose. Those were the two that were selected here to demonstrate the following steps. The team from Saskatchewan can speak to this part more, but I did want to point out that during the exercise of diagramming a process and the sub-process in detail, it can help you recognize where steps are poorly defined or where they may not be any steps yet. So right from the beginning, you can start seeing opportunities to improve. Next slide. Step three is to work as a team to brainstorm potential failure modes. So failure modes are described as what could go wrong. So potential failure modes can relate to people, materials, equipment, methods, and the environment. And examples of failure mode categories include quantity, availability, timing, quality, or effectiveness. So how do you determine failure modes? You might want to consider consulting with frontline staff, as they'll be able to tell us about their experience with the process and describe any gaps or vulnerabilities that they've observed. You can also consider published literature, including Icmp Canada safety bulletins and other forms of shared learning, so that you don't have to start from scratch. And also think out of the box and focus on plausible worst-case scenarios. Next slide. So I've listed a few identified failure modes for those selected sub-process steps. So for example, at the point when the immunizer receives the vial from the reconstitutor, a few things can go wrong. The immunizer may not recognize that the reconstitutor has provided the wrong product. So for example, maybe Pfizer instead of Moderna. Could be that the wrong volume. So maybe that dilution step wasn't done appropriately. Or it could have particulates in it. So maybe sterile procedures weren't followed, or it was stored incorrectly. So remember, this identification of failure modes or things that can go wrong is done for all the sub-process steps under each of those process steps. Step 4 is identifying the effects and causes of the potential failure modes. So in other words, if a failure happened, what would be the result or effect of that failure, and what could potentially cause that failure to occur? So as with previous example, if the immunizer did not identify that the reconstituted vial had the incorrect volume, so again, let's assume it wasn't diluted, then there would be fewer doses available per vial, and the clients would be overdosed with the concentrated product. So this lack of recognition might occur if the immunizer didn't know what the correct volume was expected to be in the vial, or because the vial itself doesn't have any measurement markings to aid with identifying what that total volume is. And again, this step is done for all the identified failure modes. And here are some tips to keep in mind for differentiating FMEA terminology. Failure modes are the what's that could go wrong. Failure mode effects are the outcomes or the plausible worst case scenarios if a failure were to occur. And failure mode causes are the whys when a failure mode occurs. Step 5 is to prioritize the failure modes. So each failure mode is assessed and given a numerical score for severity, frequency, and detectability. And then these 3 scores are multiplied together to generate what's called a criticality score, which is used to assist teams to prioritize activities for action because you'll likely have identified dozens of potential failure modes, and you can't necessarily act on all of them. The first prioritization component is severity. So this is scored from 1 to 5 to assess the effect of a particular failure, and it ranges from no effect, 1, to severe or catastrophic at 5. Frequency is an assessment of the likelihood that a specific failure would occur. So this is also 1 to 5 score, ranging from yearly 1 to hourly 5. Frequency can be determined based on known data, or it could be based on the expertise of team members. Lastly, the team needs to consider detectability. So this is a tricky concept because detectability assesses the likelihood that a failure would be detectable before the effect of that error is known. So if a dosing error is recognized after the patient has an adverse reaction, then it's not an Fmea detectable event. If a dosing error is caught right before a medication is dispensed or administered to a patient, for example, that would then be detectable. So for this failure mode, the team determined that the severity was 5. So even though the concentrated dose may not cause severe harm to the individual client, the score of 5 was chosen because fewer clients were being vaccinated with an undiluted vial, and that would negatively impact herd immunity, and there would be a loss of trust in the public health authority. The team decided that this lack of recognition may occur monthly, so the frequency score of 2, and it would be unlikely to be detected before it's administered to the client, so detectability score of 3. So in terms of detectability, since it would become obvious near the end of the vial when fewer doses than expected were drawn up, several clients would already have received the incorrect dose. So if we multiply these scores, we get a criticality score of 30. So for step 6, we're now getting into the purpose of conducting an Fmea. We're looking at redesigning the process to address the potential failure modes. Improvements can be considered based on the 3 criteria used in determining the criticality score. So safety improvements that address any of these factors, they could decrease or mitigate severity, decrease frequency, or increase detectability and make the error more visible. These will all decrease the overall criticality score and therefore the overall risk. So when considering process redesign options, it's important to consider the likelihood of long-term success. So the hierarchy of effectiveness illustrates the least and most effective strategies for change corresponding to person versus system-based strategies. Now in healthcare, we often focus on policy development and education without realizing that when used alone, these are low leverage strategies for change. And this is because they don't alter the underlying conditions that led to those system vulnerabilities. So instead, we're relying on individuals to remember the correct way to do something. Now at the opposite end, forcing functions and constraints can be found in computer systems, for example. So if we had a computer system where patient allergies can be set as a required field, it ensures that a prescription cannot be processed until that information has been entered. So as you think about an action plan to reduce the risk from an identified failure mode, it's great to aim for the highest leverage strategy that is, reasonable or possible given your circumstances. Next slide, please. During the working session, the team did identify a solution to mitigate the risk of the immunizer not recognizing the incorrect volume in the vial. So since the vial lacks markings, they suggested posting a to-scale image of the properly reconstituted vial for immunizers to compare against. So this is considered medium leverage because it is a reminder, and it's very feasible and could be implemented quite quickly. So this was a great example of a quick strategy that could be implemented. Next slide. So at step 7, we decided to proceed with a specific action, and then there are a number of ways to test proposed changes, and I've listed a few here for your review. So due to the time constraint until vaccine rollout, the team was unable to actually complete the step between completing the analysis and action plan and then implementing some of those strategies. So I've just included it here for information and completion of the FMEA process. And then step 8 is for implementing the action plan and monitoring it to determine the need for adjustments and improvements. And I've listed here a few tips for successful implementation. So a measurement plan should consider the process and outcome measures that will be monitored, and the results of measurement should be shared with team members on an ongoing basis to motivate them to continue with the plan. And so I'll just end here with a one-page summary of the FMEA process, as users find this very helpful as a quick reference guide. And I know that the Saskatchewan team used this to efficiently complete the analysis that was started with the Icmp Canada team during the working session. So I'll now turn it over to them to elaborate on some of the work done in the field following that session.
Thank you, Ambika. And everyone at Icmp for your expertise and your guidance in this project. My name is Angela Batuk, and I am a registered nurse and the Medication Safety Officer for the Saskatchewan Health Authority. My colleague AJ and I will be co-presenting today as we describe our experience using FMEA to support safety. In February of 2021, and with the guidance of Icmp Canada, the Saskatchewan Health Authority conducted an FMEA to better understand our risks related to the COVID vaccine rollout and to developing high-level safety strategies to mitigate these risks. This was a whole of Saskatchewan within a whole of Canada approach. For some background, Saskatchewan is a province of approximately 1 million people, and it covers a vast geographical area, including rural, urban, and areas with remote or limited access. Like much of Canada, weather can be unpredictable, especially in late winter, which is when we were all starting our vaccine rollouts. Our vaccine strategy included plans to open 200 plus clinics. We anticipated drive-through, walk-in, mobile, and traditional clinics. Upon review of emerging literature related to vaccine errors, which was found in the American Icmp January 2021 newsletter, the Saskatchewan Health Authority elected to develop a proactive safety strategy in order to reduce these and other potential risks. After consultation with safety stakeholders and experts, our leadership team's decision was to utilize the Icmp Canada's medication safety-based failure modes effects analysis tool. It was appealing as it was developed in Canada and it was based on the Canadian healthcare environment. Icmp Canada facilitated our workshop virtually and supported our team as we learned how to use this tool and applied it to our vaccine safety strategy development. Next slide, please. The use of FMEA to inform our COVID vaccine strategy supported our core values of safety and collaboration as part of patient and family-centered care. Collaboration occurred across SHA with our Ministry of Health and with our Provincial Public Health Office. This work also informed the greater healthcare community through partnerships with Icmp Canada and the National System for Incident Reporting. Many new partnerships emerged and supported this work. Highly skilled public health teams developed training materials, mentored and provided leadership to new immunizers from numerous backgrounds while working in clinics and non-traditional environments. Clinical nurse educators led mass vaccine orientation training sessions. Licensed pharmacy technicians supported vaccine reconstitution and the pre-filling of syringes. IT support was foundational at every level. One example among many, the implementation of the syringe label printers in the mass clinic environment to further support safe use of pre-filled syringes, benefited from the expertise of pharmacy system analysts. Custodian teams, runners, traffic controllers, all working together to keep the vaccine facilities safely operating. Next slide, please. Our COVID-19 immunization campaign goals included protecting the most vulnerable, minimizing serious illness and death, protecting our healthcare capacity, minimizing the spread of COVID-19, and immunizing as many people as possible, quickly and safely. One key campaign principle was that safety and vaccine security were foundational. Next slide, please. Reports from all FMEA sessions were then compiled by Icmp Canada, as you can see from this slide. It's a visual that captures our journey. The pillars represent our progress. The yellow and the dark green areas on the far right-hand side of your screen are still ongoing. I think it's important that we mention that all levels of the organization were engaged in this process. This was the Saskatchewan Health Authority's largest safety campaign to date. Our considerable quality improvement resources were assigned to collaborate with our support and our operations teams, and our leadership presence and involvement were integral to the success of this project. And I'm going to turn it over to AJ.
Thank you very much, Angela, for providing the background. Good afternoon, everyone. My name is AJ, and I work as Quality Improvement Lead for Saskatchewan Health Authority. Mike, could you please move on to the next slide, please? So I'll be talking about how we use the Fmea tool at the ground level. So 4 teams were formed as we decided to look into specific processes. And we attended, as Angela mentioned, the virtual sessions to learn about how to use the tool. We have facilitated working groups with the Icmp's team. All teams then reported on their work, which was summarized by Icmp. So on your screen is a sample from that report that was summarized by Icmp Canada, and it shows the potential failures and their effects and the potential causes. And then there's a section for scoring each of the failure modes for severity, frequency, and detectability, as Ambika just talked about, to calculate what is the criticality score. Our internal Fmea team then reviewed all process steps in detail and brainstormed to identify any potential failures and completed the scoring for every failure mode. Next slide, please. Once the Fmea document was complete, we needed to shortlist or prioritize our high-risk areas. So we used high criticality score, as you can see on the extreme right column there, the criticality score column, and severity 5 failure mode. So these are basically the standard lenses that Fmea tool uses. But in addition to that, we also used actual safety incidents also to identify any high-risk potential failure modes. So you can see on the potential failure modes listed here. So incorrect vaccine administration was one of the high-risk area when you have more than one vaccine at the clinic. Reconstituted vials may have labels depicting wrong expiry time, or wrong volume can be administered, which actually can lead to a second victim impact. This safety incident actually occurred and caused stress and anxiety for us. There's also a possibility of using a wrong diluent for reconstituting the vial, which may lead to an ineffective vaccine. And this has been identified having a potential of severity 5. And I would like to speak a little bit more about severity 5. It is considered as a catastrophic event that may cause significant harm. So score 5 elevates it to an override criteria, meaning we must put some strong risk mitigation strategies in place, irrespective of what the criticality score is. Normally, we try to pick high criticality score are the areas as the areas of attention. But if there is a severity 5, that makes it an override criteria. If severity 5 failure mode occurred, it may contribute to loss of public confidence and vaccine hesitancy. I would also like to add that it is very important to not just think about patient safety, but also having strategies in place to protect providers from any kind of harm. And in the next couple of slides, I'm going to share the examples of the actual scenarios and the strategies that we had put in place. Next slide, please, Mike. So in Saskatchewan, vaccine administration is based on age criteria. At the time, clinically extremely vulnerable and less than 55 years age clients were getting Pfizer vaccine, and greater than 55-year age clients were getting AstraZeneca. When we implemented this Fmea tool for the first time, we were managing the situation of having to safely provide 2 vaccines in the same clinic. So that's why we had to put some strategies in place. On your screen, you can see separating the flow of the clients. So on the picture on the right side, you'll see as the clients were walking into the facility, right after the screening, they were sent into separate streams, depending upon what vaccine they were supposed to get. We also use different cooler bags for packing different kinds of vaccines so that we eliminate the opportunity for a vaccine mix-up in the cooler bag. We had implemented dedicated staff for the distribution of different vaccine, as well as dedicated immunizer providing the administration of those vaccines. We also introduced something called special ticket system. It's like a cutout that we were giving to the clients who were going to receive Pfizer's. On the bottom left, you see that cutout picture there. This was acting as a visual cue for the immunizers to double check that, yes, these are the Pfizer clients. So they should be getting only Pfizer vaccine and not the other one. Another area that we anticipated that an error can happen, because we were running 2 vaccines at the same place, there was a chance that we by mistake make a wrong entry into our program called Panorama, where we record all the immunization related entries or details. So we wanted to make sure that we are not making a data entry error, because all of us understand the second dose is dependent on what the first dose was. So we wanted to make sure on that point too. That's where we introduced an independent double check system. One of the key points to remember while you're trying to put the strategies in place is the use of hierarchy of effectiveness that was just presented by Ambika. The idea is to always focus at the top of the hierarchy as much as possible to get that maximum leverage. Next slide, please. You may come across situations where your criticality score might not be very high, but if the failure mode occurred and has a potential for the second victim impact, meaning staff in this case, then it is worth considering those as priority areas. And that is the third lens that I just talked about that we used to identify the high risk failure modes. Incorrect volume administration was one such incident that occurred. In this example, you can see we did first plan, do, check, act cycle by implementing tent cards, indicating vaccine name as well as the volume, where both patient as well as staff, they could see it. But it caused some confusion as the client started thinking the other immunizers are administering a different vaccine and they can probably get a vaccine of their choice, but that was truly not the case. So we had to readjust our strategy or the idea immediately, and we implemented a reminder only for the staff, highlighting the vaccine of the day and the volume to drop. And that was like the second PDCA, and that really worked well. And eventually we replicated that all across the province. One thing to remember here is the solution of the strategy to different problem does not need to be like fancy one or really high tech one. The best solutions come from the frontline staff, so their engagement is really a must. And quality improvement is a never ending process, and you can always keep on implementing better ideas as they come in. And as you can see on the slide too, like we've got a couple of future considerations that we'll be working towards. Next slide, please. Talking about some of the benefits about using Fmea. So Fmea differs from root cause analysis because it works proactively instead of a reactive approach using the root cause analysis. So this tool forced our teams to think outside the box and identify the gaps that we hadn't thought about in the initial stages. And as Angela mentioned, our clinics were already live, so we had good strategies already in place and we were not starting everything from scratch. This tool acted as an extension of our efforts to embed safety in our processes. And it helped us to objectively identify some serious risks, and it allowed our teams to have discussions about the mitigation strategies of those risks. We had never used this tool before, so we also benefited by building proactive safety capacity and safety literacy across the organization. And not only the patient safety, Saskatchewan Health Authority expanded the use of Fmea tool to address emerging staff safety risks from the implementation of drive-through clinics, where staff and vehicles were in close proximity. It also provided us the platform to break down the silos and collaborate across different parts of the province to learn from and share from each other. Angela mentioned what we had like over 200 clinics and widespread across the province. So this was a good opportunity for us to collaborate. And a significant outcome from this initiative was the forging of the relationship amongst the teams across the province. Next slide, please. Talking about some of the challenges, there are challenges associated with every change project, and this was no different. At the time we started the Fmea work, our clinics had already started, which led us to have very limited access to our content experts. So leadership then utilized the quality department staff to liaise with content experts to collect the feedback from across the province. Another challenge we faced was how staff was interpreting things differently. But we had this daily check-in platform that leadership also attended on a daily basis to share the findings that helped us to identify those interpretation gaps and fix them in real time. Directives and priorities were always changing. For example, AstraZeneca age criteria and unpredictable vaccine supplies led to more than one vaccine getting administered in a single facility. This required us to reconfigure our clinics and switch our safety priorities in real time. And also review of voluntarily reported vaccines incidents revealed additional opportunities for improvement. These opportunities allowed us to collaborate with other teams like public health and clinical standards to reduce identified risks. A good example is implementation of the pre-filled syringes for Pfizer. And that concludes my part of the presentation, and I would pass it on to Mike. Thank you very much.
Thank you so much. Thanks for taking us through a small part of what must have been an enormous undertaking. And for key learning points, we've highlighted a few points about the FMEAs, mainly that they're prospective, so you're looking forward, and they rely on the systems approach, which is one of the things we really seek to emphasize here at Icmp Canada. And for med-guys, a lot of us are involved in some way with the vaccination effort. So think about how you can use some of the learning here, about how you can use FMEA to improve your practices, or if you're embarking on new practices. And if you have used this, or if your experience is different, or if you do have things to share, please tell us what you've learned. And now we'll climb up into the observatory for a really quick update from the Icmp Canada analysis team. Dorothy?
Thank you, Mike. So maybe what we'll do is I will skip entirely over this first slide in the interest of time. And with this second slide, we wanted to share from our analysis team. There's been a number of cases in Canada in which patients have received more than one first dose of a COVID-19 vaccine, and the subsequent doses that the patients received were not intentionally given as a second or follow-up dose. So over the next few slides, I will share learning from reports of patients who received two first doses in the community pharmacy setting specifically. And in these cases, the patients were screened for eligibility using a screening questionnaire. The doses were administered to the patient. The vaccination was then documented in the usual manner, including into a central, provincial, or territorial database. And it's these databases that specifically capture any COVID-19 vaccinations associated with a particular individual. So it was during this last stage of documentation when the individual documenting the dose realized that the patients that they had just vaccinated had already received a dose of a COVID-19 vaccine. Next slide, Mike. And so there were a number of contributing factors that the team identified. As part of the screening questionnaire, there was a leading question that was asked to which the patient gave a correct response based on the question that was posed. And in another case, the patient didn't provide an accurate response, perhaps because the question was not properly understood. And in these cases, the responses did not flag the patient as being ineligible for receiving the vaccine at the pharmacy. And this perhaps shows that there's a bit of over-reliance on patients self-screening for vaccine eligibility when questions may not be properly posed or understood. The cases also described a process of administering the vaccine before accessing the information from the central, provincial, or territorial databases to verify eligibility. Next slide, Mike. So this slide shares a recommended workflow, and it's very similar to the one that was previously shared, except there's an insertion of an additional step to access and verify the patient's documentation in the central, provincial, or territorial database prior to administering the vaccine, if that database is available. So this step would identify any patients who erroneously made it through the screening process and who have already been vaccinated. Next step, Mike. So the one key learning takeaway that I would like you to walk away with from this presentation is to verify an individual's vaccination status in the central, provincial, territory database prior to administration of the COVID-19 vaccine, and not after. And I believe that is the last slide. Can you just skip over, Mike? Yeah, thanks.
Thank you so much, Dorothy, and thank you to everybody, and certainly thanks to the presenters for terrific learning shared today and their efforts towards improving medication safety. We'd also like to thank you, the audience, for learning along with us. Again, please let us know what you think by contacting us, completing the feedback poll, which should be presently on your screen, or you will receive via your registration link in the near future. We also consider ourselves very fortunate to have presenters share their expertise and experience, and we'd love to count you among them. So please email us about the initiatives that you're undertaking. We'd love to hear about them and love you to share so that others may learn as well. Again, the link to the recording of this webinar will be available in the next couple of weeks on our MedSafety Exchange website, along with some of the links to some of the materials that we've gone through. So the next webinar will be in September 2021. Please stay connected as we'll let you know when the date is finalized. Thank you all, and we hope you'll enjoy the rest of your day.